So we're here today. This is our cup of tea event. We call it a cup of tea, but this is an event that's intended to bring the Canadian retinoblastoma community together for an informal discussion about a research article. Discussions center around articles which members of our Canadian Retinoblastoma Research Advisory Board, or CRAB for short, have created plain language summaries for. Sometimes we have outside partners that come in and share their research, and we welcome them to be part of our CRAB community as well. Our past cup of tea recordings are available on our YouTube channel and on our Spotify under the name Retinoblastoma Research. So I'm going to start off with some announcements. I will share a bit about the cup of tea, and then we're going to go into the article summary. It will be presented by a patient partner and a researcher, and we will have time at the end for a community discussion. So jot down your questions on the side and be ready to discuss at the end of the presentation. And so I see some people here that I haven't, that I don't recognize from past events. So this is my opportunity to tell you about a bit about a retinoblastoma research community. The community was created to connect people who are professionally or personally connected to retinoblastoma and are interested in research. You could join the community by visiting our website, rbcanadaresearch.com, and on the top of bar, there should be a spot to go and join. You could also follow us on social media. On X, we are RB_research, and for Instagram, it's at RB_research. Facebook, it's at RB Research. There we will share information, but the best way to keep in touch is by joining that, joining the community through that link on our website, and it's also posted in our chat right now. Anybody who has a personal connection to retinoblastoma, you could share this also with family and friends, anybody who's interested to be aware of what's happening, and anybody who has professional experience or connection to retinoblastoma, you could share this link with other families and with other professionals that you work with that also interact with retinoblastoma families. There are some opportunities to partner in research, and if there's anybody who has more opportunities to add, you could please jump in here and share them. But I do know the cup of tea is an ongoing event, and I'm always looking for partners to help partner on a research article and create a plain language summary and present it. So our March theme is Depict Health, and we're just working with finding our partner. If you're interested in discussing or working on an article about Depict Health with Dr. Galley, please contact us at retinoblastoma.research@sickkids.ca. And for future themes, we could work on partnering you with a theme that maybe is more impactful to your story and your journey. We also have the Patient Advocate Committee, or PAC, of the Rare Pediatric Eye Cancer, or the RPEC Biobank. You can find more information about them and what kind of work the PAC does also through that email, retinoblastoma.research@sickkids.ca. Does anybody else have any other opportunities for partners to partner in research?
Even I don't know when to say this or if it's in your slides. Do you have a save the date for the symposium?
Yes.
Oh, great.
Slides.
Okay, good. Okay, perfect.
Thank you.
That wasn't planned.
So just like the next two big events, we have the March Cup of Tea, which is a Depict Health as a topic. It's on March 18th at 8 p.m. Eastern Time. And then the 2025 Retinoblastoma Research Symposium, the dates have been set for April 5th and 6th. So put those in your calendars now. We do have the most fun when people can join us in person, if that's possible. And then this perhaps might give you some time to help plan for that trip. Also, OPAC has parent drop-ins on the 8th floor at SickKids, Monday, Wednesday, and Friday, 10:30 to 12:30. And they always have either an activity or just a good chat and a coffee. So check them out too. Okay, so our cup of tea. Today we're here to discuss an article, Trauma-Focused Support for Caregivers of Children with Severe Illness, a Caregiver-Initiated Systematic Review. The plain language summary of this article is available on our website. And this article is has not been published yet, so this is the newest research in this topic. The PDF is available on our website under the blog post that was shared in our social media. But if you go on the website, you will see it there under blog, under the December 2024 cup of tea. So we will get into that article next. We will be hearing from our guest speakers. We have BC Pomeroy. BC is a queer researcher and award-winning patient and public engagement specialist with particular interest in justice, equity, diversity, and inclusion, and has co-developed a trauma and resiliency-informed practice program for research and evaluation, a strength-based approach to patient-oriented research. BC has worked with Dr. Lindsay Jibb, and Dr. Jibb is the Singi Hijur Eaton Chair and Pediatric Nursing Research at the Hospital for Sick Children and the University of Toronto. As a certified pediatric hematology oncology nurse, Dr. Jibb's research focuses on improving quality of life and psychosocial care for children and youth with cancer and their families, including developing digital health tools, supporting family and caregivers, and advancing home-based cancer care. So now I'm going to pass over to BC. Please let me know if I'm going too fast or too slow in my slides, and you could always alert me with next slide when you're ready.
Perfect. Thank you so much. And thank you everybody for being here and being with Lindsay and I. So the intersection of trauma and grief is a project that Lindsay and I, gratefully, I submitted this to the Strategy for Patient-Oriented Research Evidence Alliance. They had an opportunity to initiate or support patient or family-initiated research projects. And this was one that I submitted, and gratefully Lindsay and her team at SickKids submitted to our RFP, and I partnered with Lindsay for this particular research project. Next slide. So we always like to kind of start in a good way. This is about being trauma informed, and a lot of the work that we do in research, as we know, can create some discomfort for folks. And so really we just want to start the time together with welcoming, or that we welcome wellness. We invite you to bring into the foreground what helps you sort of stay grounded. I am, as mentioned in the bio, I'm a queer researcher. I work here in British Columbia, gratefully on the stolen lands of the Stenomics people. I live on a little island called Gabriel Island, which is my sanctuary. I work for our provincial health services, but more importantly, my role and seat today is really as a parent of a child with a chronic complex condition. So we are going to talk about that today, and talk about my daughter Sophia's journey. So again, just welcome comfort and wellness as we sort of share a little bit about Sophia's story, and feel free, obviously, to ask questions or put stuff in the chat as we go along. Next slide, please. So this is little Sophia. This is my daughter, and Sophia was the last of my third children. And Sophia, so she has two older brothers. But shortly after Sophia's birth, our world changed forever. I'm sure some of you here will understand that in your own journeys with your own children. So Sophia began to have multiple health challenges that really encompassed the majority of her organs and systems. And it was pretty evident when she was born. We spent the first few months in NICU, where Sophia was inevitably diagnosed with a rare genetic condition. And at that time, we were sort of given hours, days, weeks, months. Her condition has no name. She remains the only documented case with this particular chromosome deletion in the world. So really, no one really knew what to expect. So we were playing catch up for the majority of her life. We spent the next 16 years sort of living our life under the umbrella of caring for a child with a chronic complex medical condition that was considered life limiting. But you can see from these pictures that Sophia, nothing stopped her in any way, shape, or form. She was, she played soccer, she danced, she went to school, she was an obnoxious teenager. sang at the top of her lungs, all those things that we love and endure and adore about our kids. She just kind of went with whatever and however her condition manifested. And again, we just sort of were always playing catch up. Her care was comprehensive. She required 24/7 care. Her health was fragile. Our nurses took her to school. They lived in our home. Eventually, we had feeding pumps, oxygen, SAP monitors, wheelchairs, all these things, plethora of medications and algorithms, again, that I'm sure a lot of you are probably familiar with in your own experiences. So I'm sure this is familiar to folks here. But sadly, Sophia did pass away January 1st, 2017, coming up to 8 years ago at the age of 16 from her condition and complications in her condition. But in those 16 years, despite being well supported for the most part, we had good relationships with Sophia's care team. We still struggled, and I still struggled as her parent and being her primary caregiver. So both within myself as well as I was looking after Sophia. And I just consistently still had issues trying to name our experiences at any given moment with members of Sophia's pretty comprehensive care team in order to advocate for our family and advocate for our family's values, our priorities, our wishes, and hopes. And I very quickly was wearing out. Thus now I have like the gray white hair very early on in my age. So we had these ups and downs in ICU 1 minute, at home, all these different things that were just sort of collecting on top of me as Sophia's caregiver for those 16 years. And we had a good community around us, but the experience still took a huge toll on me, on my emotions, and physiologically on my health as well. So I started sort of looking into how to express our experience to the care teams involved in Sophia's care in order for them to really be aware of how we may, as a family, or how Sophia may show up at any given moment, and how best to support us. And so I was, sort of trying different words and different sayings, and different ways to sort of express all that. And I'm going to get you to go to the next slide, Vanna, although I think that's your key terms. These are key terms which you can reflect on, I think. Yeah, and this is the one I really want to sort of focus on. So I started looking at how do I express what we're going through. And in talking to different people and different support resources that we had, I realized that what I was actually experiencing was this ongoing, profound, prolonged loss. And I started calling it living grief, because really it was, when you have kids that have these complex diseases and their care changes and their care progresses at these different times, you really are sort of grieving at those particular moments as you're going along. And that obviously has an impact on us. So I decided to frame living grief sort of using the Kubler-Ross model, but it didn't quite fit. So what I did is, in most parents of complex kids, us caregivers, we do things differently. So like our life, I turned it on its head and started sort of looking at this model as a way to express how we were feeling along Sophia's journey. And while we acknowledge sort of the hardships ahead, there are these sort of different cycles that I went through. So if you're familiar with the Kubler-Ross model, you know some of these for sure. So acceptance, which really for us was embracing the inevitable future sense and hope of optimism. So again, I flipped everything on its head, that I really had to accept sort of caring for Sophia, whether it was a new medication, a new piece of equipment, a new diagnosis, a new specialist. That kind of was the first sort of step for me. The second part, which I'm sure a lot of you will be familiar with as well, is this idea of depression. But really for me as a caregiver, it sort of manifested as a physiological response to caring for Sophia. So when I was in ICU for 10 days, as an example, I'd come home and I'd completely drop and burn out for a few days and often would get sick. So I kind of see that and sort of started learning that that was my physiological response to caring for Sophia. And so what did I need to put into place to look after myself in those moments? The third piece really was around this, and the third and fourth piece really was around this anger and bargaining, both from like a spiritual existential perspective of why are we going through this? What's going on? How is this manifesting in my life? Why is this happening? And then the other piece around that really was the anger and bargaining. We are in a social healthcare system, and bargaining for support for Sophia, for funding for equipment, for getting into appointments, or it could have been like an ER visit. It's, we just were constantly bargaining with the system to ensure care for our child. And again, we were in a privileged place. I wanted to sort of acknowledge that. And yet we still struggled. And again, that manifested as anger sometimes. And the healthcare teams would obviously be on the brunt of that often in our journey with Sophia. And then the sweet spot is what I call like the denial, which really is where we cling to a preferred reality. And when we're in that space and we're in this preferred reality, really that's where we kind of had our family experiences and where we found the joy and the hope and the life that we gave Sophia and that her brothers and I shared for all those years that we had Sophia. So this is just sort of how I framed it and how I look at sort of our experience as this sort of iterative, ongoing process of living grief. And this framework really helped us with language and shared language with our healthcare providers along Sophia's journey. As you can imagine, there was a plethora of them. Next slide, please. And so this is where I started doing a little bit of my own research. You know, you spend days and days in the hospital. What better to do than to sit there and look for articles that maybe can explain some of the ways that I was feeling. And so I was really struggling to better understand my grief. And this is what sort of spurred this research project. I found some of these other articles and they just like astounded me. So family caregivers experience anxiety and distress and depression at levels greater to or equal than patients. 20 to 30% of care partners experience post-traumatic stress symptoms. Only 5%, this is the one that got me, only 5% of parents who had lost their child continued to function steadily well. And this was in 2017, this paper came out. And that didn't sit well with me because what that said to me as a caregiver who'd lost a child was that 95% of us are not going to function steadily well. So what does that look like? And I definitely felt it. And saw it in my own well-being or lack of well-being after Sophia passed away. So it really kind of stuck with me. And then again, the bereaved parents on average report poor physiological well-being even many years after child loss. A lot of the grief and bereavement support we have sort of ends around year 2 or 3. I'm hitting year 8, and I can tell you I still very much need support in my journey at particular moments of the year and at particular times in my life where maybe I'm a little bit knocked out of my window. Next slide, please. And so our original inquiry, which is what I sent to the strategy for patient-oriented research, I started delving into all kinds of patient-oriented research, was doing a lot of work in this area myself as being a patient and a caregiver, a child with chronic complex condition. And when SPORE EA decided that they were going to initiate and support, patient and family initiated research, I submitted this. And this was kind of my original query to the SPORE Evidence Alliance here in Canada, was what are the events or elements of care needs over the trajectory of a child that created traumatic stress response in parents as caregivers. I really wanted to know what that was for me because I knew that I was going downhill with my health and my mental well-being, and I really just was trying to figure out how best to support myself. What are the symptoms and how do we recognize them and better screening for them, even if those symptoms don't necessarily meet the diagnosis of PTSD? I felt often in my 16 years with Sophia, I was between the cracks. I didn't have PTSD, I didn't have this, but maybe I had that, maybe I had this. And there wasn't really a lot of information or understanding of my 16 years of that living grief, that profound journey of ongoing loss that we experienced with Sophia. And then what can we learn from trauma resiliency informed practice to support and intervene in ways that are accessible to parents who are parenting a complex child or bereavement to assist with adapting to loss? Because after I lost Sophia, man, things changed. And it was very, very different than my journey those prior years. So this was our original query, and this is the call to action that Lindsay and her team jumped into wholeheartedly as we were doing this. Next slide, please. And then this was an article that's just popped up, so we're getting there. I think maybe some of you have seen this. So experiences of medical trauma among parents of children with medical complexity. So what I started to learn in sort of my bereavement and grief journey and therapy that I was going through was I was learning that actually what I've been experiencing again in those 16 years really was trauma. Every time something sort of happened. And again, what are those layers on top of me? How does that sort of manifest and show up in my everyday life now, but also during the process of Sophia? I started looking after Sophia, started sort of reflecting back. Next slide. And then this is actually our research project that I partnered with Lindsay. And so I'm going to hand it over to Lindsay now to sort of talk about the research itself. Now that you sort of understand and have a little bit of that background of how we got to where we got and why this research project was so important to us and our team. Lindsay?
Yes. So thank you so much, BC. This was, and I have to say, so BC knows this story, but the call came in from the organization to which the query was submitted in August, and it was kind of I was working on something else, sitting at my desk working on something else, saw this opportunity to be able to partner to do this work, and I just dropped everything. I just kind of said, like, whatever I was meant to do this week, it's not happening, because this work, and I think as highlighted in the last several minutes, was just it just really struck a chord with me. Even hearing the story again, and I've been privileged to be able to hear it before from BC. It's so moving to me, and I was getting kind of choked up even now. So again, jumped at the opportunity. And was really privileged to be able to work on this project, and my team. So we have a team of junior researchers, two of actually, and this is not funnily enough, I think this is a direct result of this work. So we had 3 students working on this project with us. They were so moved by the work that we were doing that one of them has gone into psychology school to be a clinical psychologist. One of them has gone back to school to be a physician assistant, and the third gone back to school to be a physician. So I think that speaks to the power of this work. But I have a tendency to ramble, and I'm not trying to just say that in a self-deprecating way to get away with doing that. It's because I'm so excited about this project, and so I'll try to stay on track. But feel free to ping me if I just kind of go off on a tangent here. So yes. So what were our questions when we started to dive into the literature? What were we looking for? We worked with an amazing health sciences librarian at the University of Toronto called Michaela. We presented to her our concept, and she helped us to refine some of our questions, and then really did the work for with regard to the search strategy, which I'll talk about in a moment. But really what we wanted to know first and foremost was, what is the effectiveness of trauma and resiliency informed care services on post-traumatic stress symptoms? So we were in fact more interested in kind of the broader impact of medical traumas on parental caregivers, but decided to focus in, because we're trying to use systematic review methodology, on one particular outcome, and then also cast a wide net so that we could catch studies that were focused on these other trauma-related symptoms. So we were also interested in how these interventions might support or not general psychological wellness, and then somatic manifestations associated with trauma too. So what are the physiological implications of being a caregiver to a chronically ill child or a child with a life-limiting illness? We wanted to look at the interventional and study quality of those first 2 of those studies that we did identify. And then very briefly, and it's very nice that that last slide was presented, which was a qualitative study looking at the experiences of caregivers, because we wanted to pull out all such studies from the literature too, thinking that in that qualitative literature we could find some very important information, not just on do these interventions work, but why do they work, for whom do they work, for whom do they not work, who's not included in the research at all, and what should be done next. Next slide. So with that as kind of our overarching goals, the aims of our systematic review are really listed here. We wanted to synthesize, as I said, the literature on the effect of trauma-informed services for either the prevention or management of traumatic stress and those related symptoms in family caregivers of children with life-limiting or complex medical conditions. And then also describe the intervention of these interventions on things like general psychological wellness and somatic manifestations in our caregivers. Next slide. So this is how we did our search. This is how it kind of showed up for us. We initially, working with Michaela, and we met with her a number of times as a large group, needed to really think about kind of how we were going to search the literature for these terms. And we wanted, as I said, to cast a wide net in terms of studies we would capture, but also some of the terms, and I didn't know this going into this, so this was a good learning for us, were quite ill-defined in the literature. So things like parent, mother, father, caregiver, what does that kind of mean? And even, you know, trauma-informed care services. What is trauma? How is it described within the literature as well? So at the end of the day, Michaela, our librarian's solution was you're just going to have to search a ton of articles by hand. I'll pull them all from the electronic databases, but your team's going to have to go through them just to make sure we don't miss anything by restricting our search terms too much. So that's what we did. We started off with 31,000 hits within our database. And again, the students on our team didn't even kind of bat an eye at that number. They were so excited about this project that they just dove in and did the work really, really quickly. So they personally screened through 15,000 of those articles. And at the end of the day, we ended up with 48 studies that looked at the impact of trauma-informed care services on the mental and physical and psychological well-being of caregivers. Next slide. This is a slide just to show you kind of how we did our work. And we did work with a big team, and all steps of this project were done in close consultation with BC. So we really didn't even, I don't know. I don't know if I mentioned this before, BC, but when I would meet with anybody who was about to come onto the project, so a summer student, I would say, we are the research assistants. Like, we don't do anything without approval from the so-called, as our funding agency called it, the patient partner on the team. So again, with that big team assembled, we developed this kind of an Excel file, which really protocolized the whole search and extraction process. So every step of the way, people on our team knew exactly what they were looking for, and were able to include or exclude studies using this kind of algorithm that we developed. Next slide. So how do we do our search strategy? Originally, we piloted the search strategy within our team to make sure that it captured relevant studies. Our step 2 was, once we had a search strategy, and it was a broad search strategy, as I said, that we were happy with, got all those results from the librarian, those 31,000, uploaded them into an online database. And then using that software, that Covidence software, we were able to kind of go through each of those hits and determine whether or not they would be relevant to our study. Then we developed an electronic form that we also piloted and used that to extract details from each of the studies. Next slide. And then just wanted to give you an idea of the breadth of details from each of the studies. We at least attempted to extract this. This is kind of what we originally wanted to get, but there's no real correlation here between what we wanted to find in the data and what we actually did. So we were interested in finding kind of just general stuff about the study. And I think for almost every study we have this. So kind of data source, country that the study was conducted in, language, study design, method, source of funding, sample size. What I will mention here is that in terms of the language, we didn't put any restrictions on our search either. Quite common to put a search restriction related to language. and say that only English language studies will be included in your cadre of studies. We didn't do that. So we did have a few studies that were published in languages other than English, and we were able to reach out to people that were kind of in our periphery who spoke those languages to support us with that study. So one of the research assistants on the team, her mom speaks Korean, so she was able to translate a Korean study for us. So that was amazing, and that helped us to kind of pull in the most diverse set of studies that we could. In terms of the family caregivers in the studies, we wanted to know, if we could, about their age, sex, gender, self-identified race and ethnicity, family income, the type of caregiver that they were, their relationship status, and then their family makeup as well. In particular, looking for whether or not there were other children in the household. And then from the child themselves, we were interested in extracting, if we could, age, sex, gender, again, self-identified race and ethnicity, diagnosis, treatment regime, and whether or not the child was alive or had passed away. And then a number of intervention characteristics too. So when we did find a study focused on a particular trauma or resiliency focused intervention, we wanted to pull out kind of everything about it, and used actually a tool called the Tidier checklist to be able to decide which of these items we would abstract data related to. Next slide. These show this slide shows you just a little bit more of the work that we did in terms of extracting data, or what we wanted to do. On the left-hand side of your screen shows you what we wanted to extract related to the trauma experience of caregivers. And then on the right-hand side, how we assess the quality of studies. We cast, I keep saying it's a wide net with regard to study type. And so this Hawker checklist here allows you to assess bias in a range of studies. So ranging from kind of randomized controlled trials to qualitative interview-based studies. Next slide. This just a slide to show you some of our Excel spreadsheets that we used to code up the data coming from each study. And what we did is we really had a look to see if we could group studies by the intervention that they claimed to be, or that they were trying to evaluate. So you can see, and I'll talk about this in the next few slides too, but you can see studies focused on acceptance and commitment therapy, cognitive behavioral therapy, some kind of a mix of therapies, so offering cognitive behavioral therapy to caregivers, and also family therapy, for instance, in that third row down. Next slide. More of the arching intervention types shown on this slide, and then all of the studies that had evaluated that intervention. Next slide. So at the end of the day, this is a really nice slide that shows kind of some of the key findings that we had from our work going through the literature. And what we really saw is studies that incorporated things like mindfulness-based practices tended to have a better chance, at least, of being effective, including acceptance and commitment therapies there. Parent skill building, also desired by parents, wanted by parents. We saw that in the qualitative studies too, but also tended to be associated with better outcomes with regard to anxiety and depression. Parents really advocated for this kind of ongoing connectedness to their care team as well. So where possible, parents really valued the opportunity to connect kind of face-to-face or virtually with either a healthcare provider at the hospital, or a trained therapist, or in some cases a peer therapist who was offering these interventions to them. And then to that point, these face-to-face interventions were valued more so by parents, and tended to be associated with better outcomes in the anxiety, depression, and traumatic stress spaces. Next slide. And then just to give kind of an arching view of what we found, sort of sum up all of the work in kind of one slide. We did, as I say, identify 48 studies. What we saw at the end of the day was that therapies that tended to work well for the family caregivers of children with life-limiting or complex medical conditions were problem-solving skills training interventions and self-guided help-based interventions, most effective at managing symptoms, as I said, traumatic stress, anxiety, and depression. ACT, so acceptance and commitment therapy, and CBT, cognitive behavioral therapy, also tended to help, but the effects did vary depending on the caregiver's situation and the therapy approach. So was the intervention face-to-face? Was it kind of meant to be caregiver-driven? Those things tended to impact on the effectiveness of the interventions as delivered. Mixed results for family therapies and written disclosures. And then other findings that therapies delivered online and remotely were relatively well received. And actually, to bring up, a tangential point, but I think important here, we are actually doing a study now looking at an intervention that's weaving in aspects of problem-solving skills training, CBT, and also relational support in the caregivers of parents with a child diagnosed with cancer at the hospital for sick children. And actually what parents are telling us is the main reason we can even do this intervention at all is because you're delivering it online. We're doing it through Teams. They said, if you were asking me to kind of leave the hospital and cross the road to go to an adult hospital to sit down for an in-person session with a therapist, that wouldn't happen. These are, and I know that people in the Zoom room are familiar with this, but parents, it's hard when I was a nurse for me to convince a parent to go down to the cafeteria and get a cup of coffee, let alone kind of leave their child for extended times for therapy. So this kind of online bit may be quite helpful for supporting parents to get engaged in these types of interventions. And then what parents really suggested at the end of the day was that, and we're seeing this also in the study that we're doing it now at SickKids, was longer sessions, more frequent meetings, and group-based activities, really wanting to be able to connect with other parents in the same position. And I think that can kind of support some of our marching orders as clinicians, researchers, policymakers, healthcare administrators, in terms of what we need to do to better support parents in a truly family-centered way. Next slide. I think that might be it, Ivana, from me.
Yeah, I think that's it.
Yes. Thank you both so much. BC and Lindsay, thank you for pushing this research forward, but BC especially for sharing your story with us and for getting this research moving from the beginning. So I was wondering if you could maybe share a little bit about that process, as I've shared questions on the screen for people attending to maybe think about and share their experiences. But how did you approach, like, even getting started on this research topic, and if you tell us a little bit more? I know you shared a little bit, but if you give us a bit more detail.
Yeah, for sure. I think like my parent partnering journey, I think started like many of us, I think, where I was originally asked to come in. We were a part of Canuck Place Children's Hospice for many, many years. Sophia got the golden ticket when she was about 2. So we did receive support from Canuck Place for many, many years in Children's Hospital. At some point in time, I was asked if I could share our story, to the staff there, to inspire, to encourage, whatever reason it was for. And then eventually, we know patient partnerships and patient engagement in influencing program and service design has evolved over the last 2 decades, thankfully, and that now a lot of us We're not, it's not about sharing our story. It's actually about sharing our wisdom and our experience to really help design programs and services in care areas that we're familiar with or we've had experience in. And that's kind of how it evolves. So just from that first story to then supporting the designing of some sort of documentation for nurse practitioners, and it just sort of evolved from there. And then Canadian Institute of Health Research, I think it was 2017, launched patient-oriented research, which really was the federal government's mandate to have patients and families and community members who are being affected by conditions and have had healthcare experiences, again, influence research, because we know really only 17% of research ever really hits the ground, a very small percentage of it. So maybe if we ask folks who are receiving these services or these treatments, what's important to them, what are the priorities, what do we need to be researching, maybe research would be more effective. And that's sort of how I got to where I got to. And then just reflecting on my experience after Sophia died, and just, obviously floundering and not really knowing where I was in my world, trying to channel some of my grief and some of my energy into really learning how to better support myself, because I wasn't actually getting, once you hit that 2-year mark, I really wasn't getting the support resources that I felt I needed. And so, and there was none available. So it was just really a matter of my own life and death that I needed to figure out how I can move forward in my life in a well way, and not like, I won't get into, like, I had heart attacks. I had, like, my body was just worn out from the care, of 16 years of constant, your endocrine system is just being beaten to death. So really for me, it was kind of a personal, journey of trying to figure it out for myself. And as it turns out, a whole pile of other people needed to know the same questions. So that's how I kind of got started.
Thank you for sharing that. I've heard in the past other people who had a personal experience with, whether it was like a childhood cancer or another illness, that get so motivated by their journey that they want to start solving it, like you were saying. And it's great that there are some resources available to help patient partners sort of take those steps, and then maybe partner with someone or find a researcher to help move them along, maybe along some of those other aspects that they might not have those strengths in.
Yeah, it's super
so
important.
Thank you for sharing
And in that process, I'm a mindful self-compassion practitioner, and in that process developed a trauma-informed approach to actually partnering in research and evaluation. So even how we have those partnerships, just those considerations for researchers, which Lindsay and her team were extraordinary, and were super open, to us kind of, it's not just what we were doing, but it was how we were doing it together in a relational way that was supporting each other with things that probably were going to be activated along the way as well. And so that piece was also, even though we didn't necessarily publish on that, I think that's a second paper, but how we did our work is also really, really important, not just the work itself.
Absolutely. Are there any questions from anyone in the audience before I continue asking BC more stuff? Okay, I do have another one. BC, I was wondering, working on this article, on this paper, and finding out the results from the research that was happening, was there anything that you were surprised by or interested to learn about as you were kind of wrapping up this research?
Yeah, I think for me, well, we joked about it a little bit earlier, so I don't know about the rest of you, but my 16 years with Sophia, and I'm a parent of 3, so I've been parenting since the beginning of time. And how often have I been told, just journal, write down how you're feeling, and I get that works for some folks and whatever, but I was gratefully surprised at the research around that piece around journaling per se isn't necessarily an approach for everybody and doesn't work for everybody. So it kind of validated my experience in that way, for sure. So there are some pieces of that, because sometimes, you're being asked to do certain things by therapists or by medical professionals or clinicians, or they look at you kind of funny, or they make all kinds of assumptions. There's all kinds of bias, as parents of these kids often with our behavior or our reactions sometimes. And for me, it just kind of affirmed that I know what's best for me in my approach as well. And so where do I find those support resources to walk through that journey in a well way? So that was kind of one piece. The other ones really didn't surprise me too much. I think for me, this was sort of a stepping stone for, okay, now what? Like, what kind of support resources can we put in place for families? What we now know what works and what may not work. So now it's like, well, what does exist out there? And I think over the last probably 2 or 3 years, hey, Lindsay, as we've been doing this, a lot more focus on trauma-informed approaches to families and caregivers, even in just the daily interactions at the hospitals, is becoming more and more highlighted. So I think that's the piece that I'll take away from this for sure. That I was super, super happy to see that those were things that were important.
And if I may just chime in to totally agree, and then say that I think also it's nice for us to be able to show that there's and I mean, BC and I have talked about this ad nauseum, and I think we're both keen to kind of move the dial here, but it was very nice for us to be able to see these interventions that may be helpful for parents. To know that we do have some tools out there in our toolbox, and as BC says, maybe we just need better ways to start to implement them. But what we missed, and I wanted to say this during my piece, but got again carried away, is that a lot of these interventions were really evaluated in very specific groups of parents, and if I'm being honest, it's kind of the usual suspects with regard to child health interventional research. And so it was people who identified as women, as mothers, as white, usually from a higher socioeconomic group, usually with at least university education. So we're really still missing a big blind spot for this area of research, is really kind of who else might this research work for. I think we need to do some exploration in that area. And another thing that BC really put me onto at the very beginning of this study, and it hadn't really occurred to me to the extent that it should have, even as a practicing nurse, was the physiological and the physical manifestations of traumatic stress in caregivers. And we really found very little, if anything, in that space. So I think there is work to be done there. We know kind of in other populations that are exposed to traumas. So, a lot of research done in war veterans, victims of physical violence, sexual violence. These physical manifestations of the trauma happen, but we've not yet had a look to see whether or not those happen at large in caregivers, for which caregivers they happen, and then how do we intervene to stop these manifestations. Thank you.
That makes me think about, this is probably like a different study altogether, but identifying the caregivers that need the support. I mean, the one way of providing the support is just to provide the same to everyone. But I wonder if even now, if any health professionals want to share, do they identify caregivers that need support and help them get that support? And how do you identify those caregivers? Somebody maybe who stands out more or shows more distress. Or Lindsay, perhaps while other health professionals are thinking about that, did any of these studies talk about that? Like how were these caregivers was just applied to all of them?
I think it's a really good point. And so in almost every case, the way that the studies were designed was to test these interventions. So it was researchers actively pursuing caregivers to be involved in the research study. But I can speak to a little bit more of a clinical, from a little bit more of the clinical care side, and speak to really, at least in oncology, the psychosocial standards of care for children with cancer, and really calling in those standards, really call in a need to do that routine screening, as you say, Ivana, of the psychosocial wellness of caregivers, and then to provide care to caregivers in kind of a stepped approach. So, there may be some caregivers, for whatever reason, are doing quite well and don't need as much intensive support. And there may be other caregivers who based on screening, absolutely need intensive support. And so that can help to, in resource limited settings, decide how resources are allocated initially. And then I think what's really vital here is the reassessment of the rescreening of caregivers over time. So not just doing this kind of once when you're first admitted to a hospital with your child, but realizing that the situation is fluid and that caregiver mental, physical, social status may change over time as well.
Thank you. Dr. Malapatna, you raised your hand, and then Caitlin can go next.
Yeah, I just want to comment that, from a caregiver's perspective, from our side, I think there's the attempt, but it's not always a successful attempt. And there are many layers to try and, address barriers to what is perceived and how people are going through care. I think our biggest resource is our social worker, Alisa. And I was wondering if Alisa had any comments there, because when we have any concerns, we always turn to her, at least at SickKids. But I'm wondering if that's if that's the norm for one from Lindsay, but if do all institutes have a social worker who the physicians can turn to? Are they part of the treating team? And I'm just wondering aloud, even Alisa's thoughts, if she can jibe in.
I'll just add to that really quickly. And then what is that? So that's at SickKids, or that's at a in a clinical setting. What happens then when that family goes back out into community? And that's, I think, also my question, with that support in the hospital, how that shared care ends up in community as well, especially in the hardly reached communities out there as well.
Right.
So I'll just add that.
Mm-hmm.
Yeah.
And I think again, because my background's in cancer, that's kind of where my knowledge stems from. But we've also recently done a landscape review of the 17 centers in Canada, and I know that has been done in the retinoblastoma by the retinoblastoma group as well. But just saw wide variation in terms of the services that different groups can offer. I think SickKids has been. And I'm not surprising anybody by saying this, but has been quite privileged in terms of having the capacity to offer more services to families. I still think at SickKids we don't think it's enough, but compared to some of the other centers, I think a lot of work is needed.
Alyssa, any comments from what Dr. Malapatna was asking, how the social work supports caregivers?
I think Alyssa's gone. Maybe.
I know sometimes we have some trouble with the mic, so if you're able to connect. Otherwise, I'm going to jump to Caitlin, who had a question.
Thanks, Eva. It was mainly more of a comment or just wanting to join the discussion. And first of all, thank you, BC, for such an engaging talk and sharing with us all about your experience and sharing about Sophia as well. I really appreciated learning that. And you really exemplified patient-led research. So it's so nice to see what you've been able to accomplish. And it's such a great story for other patients here that are maybe tentative or hesitant to lead research of their own. I just wanted to comment that you're kind of a step ahead of us, I guess, because you've established now what works and what doesn't work, with the caveats, of course, that some of that was done on the usual suspects. And now you're trying to establish how to provide that to patients and families. But in the RB community, and Dr. Jibb's part of this as well, we're kind of a step behind you, where we're still trying to even better articulate what the needs are. We know there's a need in our community to improve support, psychosocial support broadly, but we haven't really quantified that for our niche. And so we're behind you and trying to first establish that need and then trying to determine what interventions there are to meet the specific needs, which there will be probably, vision and other specific needs. And so I guess my question, with 1 minute left, would just be, in the research you guys have done, can you speak to that a bit more, like that even within the complex care or like the complex care world, for instance, I imagine there might be specific niches or unique needs in the various communities that make up that broader community. And like, do you have any worries about this kind of broader one size fits all interventions? Is there a need to make more customized, tailored interventions within that broader group?
Yeah, I mean, I think it's hard because we don't want to create that one size fits all. I mean, I'm part of the queer community, and so there's, even in cancer, there's so many gaps, for diagnostic and prevention and whatever, even within our own community. So yeah, I do worry about it a little bit, but I think that's where now I think people understand we're kind of creating these models and frameworks that people can adapt and adopt for their setting. And I think that's the trick. It's kind of like, I hate to use technology as an example, but you kind of white label things and then people can design it for their own group. But being part of the rare disease community, and Sophia was born in 2000, so there was no internet, there was no cell phones, there was no nothing. So we saw the cancer communities, even within the hospitals, there was such a huge gap between the services that we got on our ward. We didn't even have a working kettle or a coffee maker, right? So I mean, if I just even use how we're cared for, between diseases and conditions, depending on funding models or urgency or competing priorities, that exists even at the point of care. So yeah, how do we create that equitable lens for folks, with some of these resources? I don't have the answer, but I think the trick is not to make things so hard-edged. I think to understand that these are cognitive scaffoldings, and how do we adapt it even independently for each person. Like I said about the whole journaling, freaking hate journaling, but somebody else might like it, right? So
yeah,
be open to that and not be so structured in our clinical settings anyways.
Thank you. That's a good answer.
I know there's another meeting for the RB care team. They usually attends at 9 o'clock, but anyone who's not attending that and has another question, I'm happy to continue for a few more minutes if BC and Lindsay, if you're okay.
Yeah, it's early for me on the West Coast. It's only 6 o'clock.
Okay, well, I know it's late and some of us maybe need a little bit extra sleep these days. So thank you, everyone, for attending. Thank you, BC and Lindsay, for sharing this information and this article with us and your research. It's great to have this information. So I really appreciate that. And the rest of you guys have a great evening. Everyone have a great evening. Happy holidays to everyone. And stay tuned for information about our March Cup of Tea. And if you have any questions and want to be involved, you can email retinoblastoma.research@sickkids.ca.